Hi guys, I'm back with a new tutorial video. Today I'll be finishing the benign histopathological lesions in thoracic pathology. Just an overview of 10-12 minute video, and then before starting malignant I'll be doing moving ahead with myeloproliferative neoplasms and hematopath after this week. Okay, so without wasting much time, so I've covered grossing. Today I'll finish benign. I'll first take malignancies when I do. After that, investigations, and in the end, a very small 5 minute tutorial on transplant pathology. So the history remains the same. Patient can be young, can be old, can be factory workers. You know, history is very important in lung lesions because we inhale a lot of things. Can be bird keepers, depending on what the disease could be. And mostly they present with breathlessness, cough, hemoptysis, chest pain, loss of weight, fever, maybe sometimes with other systemic symptoms and autoimmune diseases like skin rashes, malar rash, hematuриas. But thing is, then there will be pointers for each of these diseases. Okay, investigation panel remains the same. So we had done certain diseases last time. Today we are going to finish the I have enumerated all these diseases which are there from the net. I have taken this, excuse me, which come under the category of benign lung lesions. There's cystic lesions like congenital cystic adenomatoid malformation. There are four types in this. Then there's cystic fibrosis due to CFTR gene mutation, emphysema, alpha-1 antitrypsin deficiency, infant lobar emphysema. Then there can be work-related diseases like those who work in asbestos industries or ships. They might develop asbestosis. Coal workers develop coal workers pneumoconiosis. Bird keepers may have psittacosis, very common in parrots. Cotton fiber beaters may have bisonosis. So these are some work-related diseases that in the lung that can occur. Then health-related diseases like you're a smoker, you develop smoker's lung, COPDs, or you have atopy, you have idiosyncratic reaction, allergic reactions, you might develop asthmas. Then there can be proper infections, which can be bacterial, fungal, viral, or parasitic. So images again in quick succession. I'll show you the first image over here. There is breaking of the walls of the alveoli which are normally maintained. This is one alveoli. So when you break up the wall and the walls break and they fuse, so they form one large cystic space like this. And if you compare it with this image, you see how well formed all these alveoli are over here. So this is emphysema. Then over here you see a lot of cystic cells filled with pink eosinophilic material. This is not a lung slide actually. This is actually, I think, a liver slide. I shouldn't have put this over here, but what I wanted to show you was this is alpha-1 antitrypsin. So that these chemicals, when they are not getting utilized, they have this pink eosinophilic dot gold coarse material in their cytoplasm. Similar things you're going to see in macrophages in a lung also if it is an alpha-1 antitrypsin disease. And this image over here shows you all these stages of the malformation, cystic malformation of the lung. There are four types, and you're going to get a lot of multiple varying size bronchiole-like cysts. You might get metaplasias, and you know, it has entire spectrum. There's an entire chapter, large number of pages of lung benign devoted to this. So yes, you will encounter this mostly if you are working in a pediatric setup. Adult setup, you don't encounter this too much. Fine. So this is very important. So these are few. Then comes the what shall I say, the work-related lung diseases. So here you can see, or the shall I see? So this thing, this granuloma like thing, the silicosis. Fine, glass factory workers. Then a lot of black pigment in the lung, large areas of black pigment with fibrosis. This is pneumoconiosis. Fine, and then these dumbbell-shaped iron calcium depositions, ferruginous bodies which are seen, and this is asbestosis. So this is very classical, and then you don't have to think too much, because if this is there, then you are rightly, at the diagnosis. So these fibrotic areas in silicosis, they give that eggshell appearance, and there's a lot of calcification in them sometimes. So they give that eggshell appearance on X-ray, okay, cracking eggshell kind of an appearance. And pneumoconiosis, sometimes there are autoimmune manifestations, and there are special names for that. So that all that is given in the book. Go through it. It is important. It is asked. Then just a comparison to show you that we always there are two types of lung disorders. One is restrictive, and one is obstructive. Fine. One is where there's some sort of an obstruction to your normal breathing. Because of that, there's some problem in the lung. And one is when the breathing passage is clear, but the lung wants to expand, but there's something outside the lung which is stopping it from expanding. And then that is restrictive. Now, asthmas and COPDs come into the obstructive lung disorder category. Just an image to show you what happens in asthma has a lot of reaction to some atopy where the muscle in the bronchial wall, this is the muscle, this goes into spasm. And you know that not every episode of asthma leads to death. So multiple episodes lead to thickening of the basement membrane of the asthmatic patient's bronchus, which might not be seen in other types of COPDs. However, and marked inflammation can be seen in both types of COPDs. More of eosinophilic infiltration can be seen in asthma. However, other types of COPDs have more of fibrosis, which is not there in asthma. So when you get a sample and you need to so in that sample you can define that what kind of COPD this could be. Okay. Another this image is there in your books, so in Robbins, etc. So go through it. You should remember the difference between bronchiectasis and a normal. We used to remember it this way, that there's the wall, the mucus gland, then the cilia, and then the air passage, and the mucus gland has some mucus, and the cilia are these hair-like. What happens in bronchiectasis is that this mucus gets increased, and this mucus starts penetrating the wall, and hence the entire wall gets destroyed. Normal bronchus looks like this. So this is just an image to show you that when you are looking at a micrograph and seeing changes only in bronchus, and the bronchus is getting destroyed, and that lesion is bronchiectasis. Then there can be infective diseases like fungal. Here you need to know what are the angio-invasive fungi and which fungi, like mucormycosis. What is mucormycosis? Very, very common these days due to COVID, right? Also known as the black fungus. And then aspergillosis is very another common. Bronchopulmonary aspergillosis is very common. Histoplasmosis is very common. Coccidioidomycosis is very common. So there are lots of infective tuberculosis is very common. Other fungal infections can be the interstitial pneumonias due to viral infection. Atypical mycobacterial infections can be there. So it's a large spectrum. So in fungal, what you need to remember is acutely branching and and obtuse branching of the fungal hyphae. What fungus show that, and features of aspergillosis and mucormycosis. Important, will come. There can be sarcoid-like granulomas which are non-caseating, or tubercular granulomas which are caseating. And lastly, pneumonia, I wanted to just briefly tell you, pneumonia has 4 stages. There are stages of acute inflammation and edema, where you'll get alveolar exudates and a lot of material and inflammation in the alveoli. Then is red hepatization, where extravasation from leaky capillaries leads to RBC collection in the alveoli with inflammatory infiltrate. Gray hepatization means The lung looks gray like a liver, and hepatization means because it is looking like a liver, congested, heavy, soggy rather than spongy because of infection and inflammation. Gray hepatization is when the infection is contained, edema is reduced, there's still inflammation, but edema starts receding, and then resolution. Edema disappears completely. There's some inflammation, some debris, and macrophages might appear. Okay, and mostly gray hepatization is after a week, and resolution after 7 days. So in short, see, I told you it will be a 10-minute tutorial. So this was finishing the benign lesions of the lung. Next video that I upload will be of myeloproliferative neoplasms. So stay tuned, and if you like malignant hematology, do go and check out my book. This is present on the Google website on Ahuja booksellers site, and do review and tell me whether you enjoy the book or not. Thank you.